anesthesia and surgical intensive care. Dr. Ibrahim is also having a European diploma of anesthesia and is currently a consultant anesthesiologist at Dr. Suleiman Al-Habib Medical Group. Welcome, Dr. Ibrahim.
Thank you very much. Good afternoon, everyone. Today, my topic is about deep neuromuscular block. Is it really important? This is my disclosure. I'm working in the Dr. Suleiman Al-Habib Hospital, and I'm a professional speaker for MSD. In the last 3 decades, there was an increasing in laparoscopic procedures versus laparotomy cases. And most of the laparoscopic cases done before by using laparotomies, we are now using laparoscopy in these cases. And as you can see, since 1990s till 2011, almost 100% of the cases they are done now under the laparoscopy. In laparoscopy theaters, there is 2 lines of interest. The first line is the surgeon's line of interest, which the surgeon aims to be fast and has an easy access, no injuries, and no bleeding. The other line of interest is the anesthetist line of interest, which aims to have a stable vital signs, fast recovery, no neuromuscular blocking residuals, and no pain. Actually, these 2 lines are parallel lines. According to geometry facts, parallel lines never meet. But in OR, these parallel lines must meet. If we have a close-up on the aim of the surgeons and the aim for the anesthetist, they are both related to neuromuscular agents. From the surgeon's perspective, there is 2 basic questions which we have to answer first. These 2 questions are related to neuromuscular blockage. What are the components of the ideal surgical conditions, particularly during laparoscopic procedures, and what are the challenges to achieve these ideal conditions? What's the meaning of ideal surgical conditions from the perspective of the surgeons? It means that he has a larger operative space, he had a better visualization, and also in tight, he can access tight spaces during procedures. Also the access, there should be, the patient should be immobile all the time, because any mobility or any movement during the surgery, there is a big risk and big, because there is great vessels and the intestine nearby the procedure. And also, he keen about using lower insufflation pressures. Our aim as anesthetists is to do safe, balanced anesthesia. As we know, safe, balanced anesthesia has 3 components, which is hypnosis, analgesia, and relaxation. And to keep the balance in these 3 components, sometimes it becomes very difficult, and we need to do this balance to have a balanced and safe anesthesia. Professor Churchill Davidson, in 1958, he was the first one who described the role of nervous stimulator in monitoring of neuromuscular blocking agents. And Professor, the great Egyptian Professor Hassan Ali, was the first one who described the train of 4 as a method of, to monitor the neuromuscular agents. When you can see here, the neuromuscular blocking is divided into 2 components, the moderate and the deep neuromuscular block. The moderate neuromuscular blocking means the train of 4 count is 1 to 4. And deep neuromuscular block means train of 4 is 0. We cannot get train of 4 switches, but the BTC or positive time count is 1 to 2. Here there is another classification done by Naguib Ayal, making neuromuscular depth, blocking depth on 7 levels, starting with level 1, which is acceptable recovery, level 2, when the train of 4 ratio from 0.4 to 0.9, this means minimal block, level 3, when the train of 4 is less than 0.4, it means shallow block, And level 4, moderate block, when is frame 4 is 1 to 3. Level 5 is the deep block, which is a post-tetanic count more than 4, and frame 4 count 0. Level 6, which is called profound block, when you have post-tetanic count 1 to 3, and the level 7 complete block when the post-tetanic count is 0. Deep neuromuscular block versus moderate neuromuscular block. Does it really worth it? Because deep neuromuscular block means you have to cost more drugs, you have to give more drugs to achieve this depth of neuromuscular blocking. And also there is a risk that the patient may have residual of neuromuscular blocking. Does it really worth to give all these drugs and to reach the patient to be deep in relaxation? You can see here this study, it's done on 100 patients and it's done on bariatric cases. And now we have a very big growth in bariatric surgeries, especially here in Saudi Arabia. This study was evaluated by 3 surgeons, and these 3 surgeons make evaluation every 10 minutes using a scale which is called the surgery rating scale, surgical site rating scale, and they also monitor the pain in BACU and in the ward. If you look here to the first curve, this score actually, the SRS score is composed of 5 points, which is 5 is the best view, best field view, and 1 is the worst field view. This orange line up there are the patients who are taking, which was 50 patients who are taking deep neuromuscular block, and the yellow line here, yellow dots, the blue dots are the patients who received moderate neuromuscular blocking. You can see here a significant difference in the evaluation of these 3 surgeons between the patients received deep neuromuscular block and the patient received moderate neuromuscular block. Also, in the BACU, there is good difference between the patient received the deep neuromuscular block regarding pain and regarding the morphine consumed in the recovery area. Here, the patient received neuromuscular blocking, the ratio is 3.9, and in the moderate neuromuscular block was 4.4 compared to the moderate neuromuscular block, the pain score. And regarding the morphine given in the recovery area, in the patient who received deep neuromuscular block, it was the average was 3 milligrams, and in moderate neuromuscular block, the average was about 4 milligrams. Also, there was a follow-up to these patients in the wards, and we can see here some big difference in the pain in patients received deep neuromuscular blocking and the moderate neuromuscular blocking, and also in deep wound pain, there is some difference, 1.8 compared to 2.3. Actually, theoretically, the reason of decreasing pain here because the deep neuromuscular block is usually associated with less intra-abdominal pressure, and less intra-abdominal pressure associated also with less pressure of the diaphragm, less release of the mediators of the pain. That's why there was some relation between postoperative pain and deep neuromuscular block. Here there is another study. This study is for patients who done laparoscopic cholecystectomies, and this study was a multi-center study on 11 centers, and it used 127 patients. This study was done in Austria, Finland, Germany, Italy, and UK. And most special in this study, it's used 2x2 factorial design. This means that they were comparing the patient who received moderate neuromuscular blocking and moderate pressure, intra-abdominal pressure. Moderate intra-abdominal pressure here means they have a pressure of 8 millimeter mercury and 12 millimeter mercury, and low pressure means 8 millimeter mercury. So they were comparing between patients who received moderate neuromuscular blocking and moderate pressure, intra-abdominal pressure, and the patient who received moderate neuromuscular blocking and with low intra-abdominal pressure. Also, the patient who received deep neuromuscular blocking with moderate intra-abdominal pressure and deep neuromuscular blocking with low intra-abdominal pressure. In the graphs, you can see that the moderate neuromuscular blocking was less regarding using the same scale, LSRS scale. It was less than the deep neuromuscular blocking. Means the surgeons who did the evaluation of the surgical space, they said that the deep neuromuscular blocking was giving better visualization of the field. But actually, between moderate pressure and low pressure, most of the surgeons, they like the moderate pressure than the low pressure. But if we look here down, we will find that between the patients who receive deep neuromuscular blocking with low pressure and moderate neuromuscular blocking with low pressure, the deep neuromuscular blocking with low pressure was better. The mean there is better than the patients who received moderate neuromuscular blocking while using low intra-abdominal pressure. The next study, this study was published in British Journal of Anesthesia, and this study was done on the patient who did laparoscopic prostatectomy and or nephrectomies, and they used 24 patients in this study. In this study, actually, the unique thing in this study that the one who evaluates the surgical field is not the surgeon himself. Because sometimes it's getting confusing when you ask the surgeon, please evaluate the field, because in the surgeon's mind, he's not evaluating only the surgical field. He's evaluating all the case. Was the case easy or not easy? Myself, in my practice, sometimes I was asking some of my surgeons, please evaluate the surgical field. And what the surgeons they are saying, I cannot give you score from 1 to 5, but I can tell you if the operation was easy or was not easy. So it's because in consideration, the surgeon is putting a lot of considerations in while doing evaluation. So in the most specific thing in this study that they took a video images of the surgeries and they asked 12 anesthetists who rated the images, not the surgeon. It was anesthetists who rated the images using the same scale, which is SRS, but not the surgeons who rated the surgical field. We can see here that comparing the moderate neuromuscular block compared to deep neuromuscular blocking, most of the cases were done under the deep neuromuscular blocking, they were taking score 5 or 4. But some of the cases here in moderate neuromuscular blocking, some cases taking sometimes rate of 1, 2, or 3, and most of the cases were taken rate 4, and the cases of rate 5 was less than 50% of the cases. Also in this study, they follow up the pain of the patients, and the pain score of the patient receiving moderate deep neuromuscular blocking was less than 2.1 compared to 2.6. And also the sedation score was 1.3 compared to 2. And this sedation score was as a reflection of how much morphine given the intraoperatively or post-operatively. The coming study, they didn't use an indicator like SRS indicator in this study, but they used actual measures. In this study, they are doing this study. They were measuring intraocular pressure in the patient doing laparoscopic radical prostatectomy. Actually, the surgeon was starting with pressure 20 millimeter mercury and was decreasing the pressure down till he reached the least pressure that he can work comfortably during the operation. They found that 6% of the patients who had moderate neuromuscular blocking, the surgeons has to use a pressure of 20 millimeter mercury, which is very high pressure. And 34% of the patients who received 34% of the patients who received moderate neuromuscular blocking, the surgeons used a pressure of 15 millimeter mercury, and in on pressure 12, 6% of the patients on deep neuromuscular blocking can do the surgery under pressure of 12, and 22% only of patients on deep neuromuscular blocking moderate neuromuscular blocking can do under pressure 12, and up to pressure of 8 millimeter mercury. On pressure of 8 millimeter mercury, the patients who receive deep neuromuscular blocking, 88% of them, the surgeons can do the surgery on the least pressure, which is 8 millimeter mercury, and we said before the relation between the intra-abdominal pressure and the post-operative pain. Also, there was a measurement of the intraocular pressure. Measurement of intraocular pressure was done on specific times, time 0, time 1, time 2, time 3, up to time 8. And each time here in the schedule is related to some stage of the surgery. For example, T0 is before the anesthesia starts, and here we can see patient who received and who didn't receive were the same. T1 means 5 minutes after anesthesia and induction. After anesthesia and induction, we see here the patients who received deep neuromuscular blocking. They were, which is group D, the line below, shows less intraocular pressure, and T2, which is 5 minutes after establishing CO2 insufflation. We can see here after insufflation, they will both look like the same. And T3, which is 30 minutes after insufflation, and T3 and T4, which is 30 minutes and 60 minutes, which is almost during all the time of the surgery. We see here a significant difference between the pressure, intraocular pressure between the group who received deep neuromuscular blocking and the group who received moderate neuromuscular blocking. Here we see some articles and some meta-analysis which were published in many journals like the European Journal of Anesthesia and British Journal of Anesthesia, and all these meta-analysis, they are saying that deep neuromuscular blocking is better than moderate neuromuscular blocking in maintaining a better field for the surgeons. On November 16, means 2 days back, we had these guidelines which was released by the European Society of Anesthesiology. This guideline is about the perioperative management of neuromuscular blocking. This is very updated, only 2 days back, and there is some recommendations. They give 8 recommendations, and the 8 recommendations were: recommendation 1, we recommend using muscle relaxant to facilitate tracheal intubation, which was high quality of evidence and strong recommendation. Recommendation 2, we recommend the use of muscle relaxants to reduce the pharyngeal or laryngeal injury following endotracheal intubation. Recommendation 3, we recommend the use of fast-acting muscle relaxants for rapid sequence induction, such as succinylcholine, which is 1 milligram per kg, or urocuronium, which is 0.9 to 1.2 milligram per kg. Let's go here for recommendation 4, 5, 6. Recommendation 4, 5, and 6, and 7, and 8 also, they are very close to our topic today. If we see in recommendation 4, we recommend deepening of neuromuscular blockage if surgical condition need to be improved. And it's a moderate quality evidence and has a strong recommendation. So we have here a clear recommendation from the European Society of Anesthesia that deep neuromuscular blockage gives a good surgical condition to the surgery. Also, recommendation 5 that there is insufficient evidence to recommend deep neuromuscular blockage in general to reduce post-operative pain or decrease the incidence of perioperative complication. Till now, we don't have sufficient data or sufficient evidence that the theoretical mechanism of reducing pain with deep neuromuscular block is effective. So, according to the recommendations, there is still a weak recommendation about the link between reducing post-operative pain and the deepening of neuromuscular block. In recommendation number 6, we recommend the use of ulnar nerve stimulation and quantitative neuromuscular monitor at the adductor pollicis muscle to exclude residual of paralysis. And it's a moderate quality evidence and strong recommendation. In recommendation number 7, we recommend using Sogamidex to antagonize deep, moderate, and shallow neuromuscular blockage induced by aminosteroidal agents like leucuronium or vicuronium. Here he is describing the deep is post-tally more than 1, and TOF count is 0, and TOF less than 4, which is moderate or shallow. TOF from 1 to 3, which is moderate, and shallow, which means TOF count of 4, which is high quality evidence and stronger recommendation. So we have now another recommendation from the European Society of Anesthesia. They're recommending using Sugammadex as a reversal from vicuronium or leucuronium. Also, recommendation number 8, we recommend advanced spontaneous recovery, which is TOF ratio more than 0.2 before starting neostigmine based reversal, and to continue quantitative monitoring of neuromuscular blockage until TOF ratio is more than 0.9 has been attained. If you are going to use the neostigmine, you have to wait till the TOF is more than 0.2, and the TOF when it reaches 0.9, that time it's safely to extubate. Is it worth the cost? Is it really, as we said in the beginning, okay, now we have clear evidence that the deep neuromuscular block is superior in moderate neuromuscular block. But actually the health service or the hospital, whatever, or the patient will have more cost because you are using more drugs. So is it really worth the cost? In Boston 2017, Christian Martini and Martin Boone, they gave this retrospective, they presented this retrospective study on effect of neuromuscular blocking on healthcare resources utilization. And they would make this study, this retrospective study on 229 patients who received a deep neuromuscular block versus 229 patients who received moderate neuromuscular block. And they had a result that there was no effect on duration of anesthesia, duration of surgery, use of opioids during anesthesia, use of vasoactive medication, blood pressure, heart rate, bispectral index, PACU, or hospital stay. And also they have another surprising result, which says that the readmission within 30 days in deep neuromuscular block was only 17 readmissions, and the patient received moderate neuromuscular blocking was 29 patients. And it was actually, there was a statistical relation because the P value was less than 0.05. So there is a relation between readmission rate and using the depth of neuromuscular blocking. So the the deep neuromuscular block is safe and result in less readmissions. Also, there is another study. This study is speaking about Sugammadex for reversal of neuromuscular block, a retrospective analysis for clinical outcome and cost effectiveness in a single center. In this study, actually, they counted the cost of the OR costs regarding the fees for the doctors, the nurses, even the workers, all the workers inside OR, and they counted the total cost per hour, and also they measured how much time saved when using Sugammadex. Here in this graph, you can see here is the patient control group who didn't receive the deep neuromuscular block, who didn't receive neostigmine, and the treated group who received Sugammadex, and the patient on this blue line who received Sugammadex. And you can see here that there is, in the time, there is some reduction of the time if you are using Sugammadex. And regarding the cost, if you compare Sugammadex to neostigmine, there is a great saving in, you can see here from $1,000, $2,000 up to $2,000 up to $20,000 in the reduction in the cost if you are going to use Sugammadex. Now, how to be safe? We said before, one of the most things that anesthetists shall be worried about is neuromuscular blocking resilience. So, how to be safe in doing deep neuromuscular blocking? Reversal, this study was very attractive. It said if you are going to do reversal with Sugammadex In the absence of monitoring, did this preclude that no residual neuromuscular blocking if you're going to give Solomedex? This means that the patient is fully reversible. They found that 9.4% of the patients who received Solomedex, 9.4% of these patients didn't reach the safe point of extubation, which is TOF 0.9. So they found that the risk of TOFR less than 0.9 is still exists when you give Solomedex in 9.4%. So it's important to use neuromuscular monitoring when Solomedex is used for antagonism of oxyuranium-induced neuromuscular blocking. The American Society of Anesthesiologists put some standards for basic anesthetic monitoring. The standard one, which is the anesthetist himself, and standard two, as we know, is oxygenation, ventilation, and circulation and temperature monitoring. Also, there was a good rise in doing guidelines regarding neuromuscular monitoring, as the neuromuscular monitoring is considered one of the basic monitoring in OR right now. And as we start since 2010, there was a guideline done by the European Society of Anesthesia in Helsinki, followed by 2010 the Czech Society, and 2012 the European Board of Anesthesiology, 2017 until we reached 2021, which is done by the Spanish Society of Anesthesia. And actually, the guideline, which is done 2 days back in 2022, we can add it to this list as a recent guideline, which is a neuromuscular monitoring guideline.
3 minutes.
Now let's have a very fast tour on these guidelines, which are the recommendations from the Association of Anesthetists of Great Britain and Ireland. They said that quantitative neuromuscular monitoring should be used whenever neuromuscular blocking drugs are administered throughout all phases of anesthesia, from before initiation of neuromuscular blocking until recovery of 3 or 4, and ratio to more than 0.9 has to be confirmed. Next, the Canadian Society of Anesthesia, they give recommendation for the use of neuromuscular monitoring when neuromuscular blocking agents are administered, has to be strengthened from should to must be utilized, and neuromuscular blockade monitors are now considered required equipment when previously they are only exclusively available when neuromuscular blocking agents are used. The last one in these guidelines is the French Society of Anesthesia. They give recommendations that the intraoperative monitoring of neuromuscular blocking throughout anesthesia when a muscle relaxant is administered. These recommendations applies both in the operating theater and post-anesthesia care unit. Qualitative measurement of the ratio between the fourth and the first TOF response, more than 0.9, is required to eliminate the diagnosis of residual neuromuscular blocking. Let's go for take-home message. Deep neuromuscular blocking may facilitate. It's not may now. It's actually, according to the guidelines, it says it facilitates the use of reduced insufflation pressure without compromising the surgical field of vision. Also, deep neuromuscular blocking was associated with reduction in post-operative fail scores. It's still not on the guidelines, but in the post-anesthesia care unit compared to moderate neuromuscular blocking. Also, a proper selection of neuromuscular relaxants and adequate monitoring of complete reversal should become the first part of the surgery. And we have here to stress that the monitoring is very essential. Neuromuscular monitoring is very essential during and after the use of neuromuscular blocking agents, because the neuromuscular monitoring will tell you how much drugs are we going to give. Because sometimes they ask, this is a common question, how much drug I have to give to reach deep neuromuscular block. I cannot give you a specific dose of drug to give to reach deep neuromuscular block, but you have to monitor the patient to find out what is the post-time count now, what the TOF ratio now, and according to your reading, to your monitor, you shall give drugs to reach the point. And also during recovery, you must use neuromuscular monitoring because according to the neuromuscular monitoring, it will tell you when safely you can extubate the patient when the TOF ratio is more than 0.9. Thank you very much.